We all have followed survival curves over the last 5 and 10 years. And in this, if we look at the overall survival curve, there's always, unfortunately, somewhere between 10, 15, 20% of patients that unfortunately don't survive the first 3 years. And so our treatments are hopefully for the broad group of patients with myeloma, but also are going to help those patients that don't make it in the first 3 years. Those are really the tough ones in my mind. um, and so uh, a lot of the clinical trials that we've done have basically focused on frontline therapy or newly diagnosed myeloma patients. And the frontline therapies have been for the broad group of patients with myeloma, but we always pull out the high risk patients and see if there's been a benefit in the high risk patients. I would say some of the things recently that you know, have caught my eye are the ones I kind of really like. One actually is a trial that was done in Italy. It was called the Forte trial. This is a trial that was actually a three-arm randomization at the start. And the goal was to test a couple things. One, carfilzomib, lenalidomide, and dexamethasone, that triplet as frontline therapy versus carfilzomib, cyclophosphamide, and dexamethasone. So KRD versus KCD. It was very easy. The first presentation was a few years ago. It was very easy to show that actually a PI plus an IMID index is much better than a PI plus an alkylator, an IMID. So KRD won. But the other randomization was actually to KRD for 12 cycles and no transplant versus KRD 4 cycles, single transplant, and then KRD 4 cycles of consolidation. And over time, we've seen that the KRD 4 cycles plus transplant plus 4 cycles of KRD consolidation was better for the majority of patients. And that included patients that had high risk disease. And that transplant is probably still in the transplant eligible is still a very important component. Now, at this year's past ASH, they actually updated data. There was another randomization at maintenance, and the maintenance strategy was either so all the patients in all the arms got randomized to either just Revlimid as maintenance or Revlimid plus carfilzomib as maintenance. And the maintenance was meant to go on until progression or intolerance. And in fact, what they showed uh, was that during maintenance with KR versus R, more than 40% of patients had a deepening of the response with KR, and there was only maybe 30% with R. So the deeper the remission, um, the better, and the doublet did better than singlet. Kind of no surprise. But what was really surprising is that was actually important for the high risk patients, but it also was important for the non-high risk patients, that the non-high risk patients benefited too in a subset analysis, which is kind of cool. So for me, for the high risk, I think it's a great regimen. The other regimen that was updated at ASH was the Griffin trial, which was a randomized study of RVD versus daratumumab, a CD38 antibody, plus RVD, lenalidomide, bortezomib, and dexamethasone. So a quadruplet versus a triplet. I think everybody knows about this study. But that said, they updated it to 1 year into the maintenance-based therapy. So it was KRD 4 cycles, transplant, KRD consolidation, and then KR maintenance versus RVD 4 cycles, transplant, RVD consolidation, and then just R for maintenance-based therapy. There was no second randomization. And essentially, they showed the PFS at 24 months was 95% in the DARA KRD arm. Actually, it was quite good in the RVD arm too. So we need longer follow-up. But in subset analysis at the 12 months post maintenance, there was a benefit again for all patients getting DARA RVD, including the patients that had high risk cytogenetics. So I think that's also a really good regimen for patients that have high risk cytogenetics. Unfortunately, in the US, in my mind, specifically in San Francisco, because I'm in San Francisco, very difficult for me to get insurance approval of DARA RVD, where I can definitely do carfilzomib RVD for patients who have um, high risk disease. Now, those are data that have been presented in the kind of the non presentations, or what we don't have data for yet. But the exciting trials, in my mind, the exciting trials, I think, are to use CAR T cells as consolidation therapy for these people. So there's a number of trials going on right now. In fact, if you do a clinicaltrials.gov search, you'll get 10 or 20 trials ongoing in the U.S. and also China and other places outside the U.S. But specifically, BMS has a trial that is looking for patients that have these high risk cytogenetics and elevated beta 2 microglobulin. So that revised ISS stage 3 disease at diagnosis. And they're getting induction therapy followed by CAR T cell therapy. And I actually think that'll be really interesting. The Penn group is doing a study also. I think they've actually completed accrual on their study. So we're all hoping to see data soon. And their study is, this was also induction therapy followed by BCMA targeted CAR T cell therapy. But I think their study actually was also in some patients to do dual CARs. So it's BCMA targeted CAR plus a CD19 positive CAR, with the thought that in these high risk patients, they may have more myeloma stem cells, and the stemness might be defined as having CD19 on the cell surface. And so you do a CAR for BCMA, which is on the myeloma cell, but also to the CD19, which might be the myeloma stem cell. So we're all looking really to those data. It'd be really exciting. I actually think, I do think that CAR T cell is going to work, but we'll just have to see, when they're presented. Hopefully we'll see them in the next year or two.